مريم تدخل. مش مشكلة. دكتور عبدو، دكتور جمال، دكتور جلوريا.
Yes, hello everybody. Come on, we can. I think we are ready to start. Dr.
Yes.
Monk, أهلا وسهلا.
If you are okay, we start. Huh?
Yeah, please go ahead.
Thank you very much. So, as the chair of the Afro Transplant Committee, and on behalf of all our committee members, it's a great pleasure to reconnect with you on the occasion of our second webinar. This webinar is part of a series that we organize every 2 months, alternating between providing an overview of the current situation and challenges of renal transplantation across various regions of Africa and addressing specific scientific topics relevant to our continent in this field. As you are aware, today's theme, the specificity of infectious complication in Africa after renal transplantation, is highly relevant. In this webinar, we will delve into the challenges posed by infectious complication in the African context and explore the most effective strategies to address them. I would like to extend a warm welcome to all of you, with special thanks to our moderators and speakers who have graciously accepted to contribute to this session. Your participation is invaluable and deeply appreciated. I also want to express my sincere thanks to the organizer of this event, particularly the webinar subcommittee coordinators, Professor Gamal Saadi and Dr. Mariam Khabar, for their diligent efforts in bringing this program together. Without further ado, I will now hand over the floor to Professor Saadi and Dr. Khabar to introduce our distinguished moderators. So, Dr. Gamal, please.
Thank you very much for the introduction, Professor Mongi, and we are all appreciating your sincere efforts in pushing forward all the activities of the Transplantation Chapter Committee. And I believe we are progressing in all the subcommittees in a very enthusiastic manner. And I believe that setting up the guidelines is very fruitful and very practical aspect which we are all awaiting. And I believe these topics we are discussing will be a backup to the setup of the guidelines, because the topics we are speaking about will highlight the importance to set the priorities of our African practice in setting the guidelines. So they are all complementary activities, and they are not at all separate or not in integration. So I believe this webinar tonight will be very fruitful in the setting our practice and our guidelines. I would leave the floor to Professor Khaddar to introduce the speakers and the moderators.
Please, Dr. Gamal, if you could introduce the two moderators, because Dr. Khabar have a small problem with the connection.
Yes, please. Our moderators tonight are very two eminent nephrologists, and they are all very close friends to me, and I'm really pleased to have them among us tonight. Professor Abdou Niang from Senegal and Professor Gloria Ashuntatang from Cameroon. They are very close friends, and it's always a pleasure to have them among us. So please proceed, Professor Abdu and Professor Gloria.
Hello. Thank you, Professor Gamal Sadi, for this nice introduction. And I would like to thank Dr. Mongi for the great job you are doing now in the Afghan transplant chapter. And it is very important for African community to have regular webinars like this for training fellows and nephrologists in the continent. That's why it was a pleasure for me to accept to join all the nephrologists in this excellent and very interesting webinar. I'm very happy to co-chair with my dear friend Gloria Ashutantan. I will let her to give some words. Welcome, Gloria.
Thank you very much, Abdul, and welcome to the Afran family. It's a great pleasure for this webinar, and I'm really looking forward to it. Thank you very much.
Thank you, Gloria. It is my pleasure to introduce our first speaker, who is Dr. Hussein Baga. He is a consultant physician and nephrologist working at the Shah Hospital, and he is the head of the renal and transplant unit, and also he heads at the Department of Internal Medicine. Dr. Baga did his Master's of Internal Medicine at the Agan University and his nephrology training at the University of Witwatersrand in South Africa. He's also completed his MRCP nephrology. Dr. Baga is member of Royal College of Physicians, and Surgeons, and the Fellow of International Society of Nephrology and the Royal College of Physicians. He presented at several international forums, and his main interest is in kidney transplantation, cardiorenal syndrome, and diabetic kidney disease. Please, Dr. Hussein Bagan, you can begin your lecture.
Thank you very much, Professor, for those kind words of introduction. I hope you guys can see my screen and hear me.
Yes, Hussein.
Yes, we can see the screen, yes.
Yeah. Thank you very much. It is indeed an honor to be here in this forum presenting with my teacher and mentor, Professor Paget, where I trained at the University of Witwatersrand. It's indeed an honor to be on the same platform as him. So I would like to really thank the Afghan Transplant Committee for inviting me to give this talk. So I'll be talking about bacterial infections in the post-kidney transplant patient. I'm going to start off with a case presentation about a patient who was transplanted in my unit very recently in June. He was a 25-year-old male known to have type 1 diabetes mellitus, systemic arterial hypertension, and of note was that he was previously treated for pulmonary tuberculosis, which is why his transplant, which was scheduled in 2020, was actually stopped. His medications prior to the transplant was just on insulin, and he was not on any medications for his hypertension. His blood pressures were quite well controlled. He underwent a living-related kidney transplant on 11th June 2024 with a 2-to-2 mismatch. He was given basiliximab induction, and as is routine in my transplant center, there was a ureteric stent that was put in during the surgery. However, during the surgery, he developed intraoperative hypotension, subsequently had delayed graft function requiring hemodialysis for more than 2 weeks. During the stay, he had sepsis. The focus was unknown, but most likely was surgical. He was treated with tazobactam and piperacillin. Had been started on isoniazid prophylaxis. We don't routinely do that in my center. But because of his prior history of TB treatment, he was started on isoniazid prophylaxis, but developed liver dysfunction. And after consultation with the hepatologist, we opted to stop it, and his liver function subsequently improved. His allograft function improved subsequently, and he was discharged on tacrolimus, MMF, and prednisolone. He developed a lymphocyl, which basically was drained laparoscopically. 5 weeks down the line, he came for his routine assessment. He was passing urine normally, had no dysuria or increased frequency, no fevers, no abdominal pain. He did some routine lab tests, which included a urinalysis, his complete blood count, and his TAC levels. So his urinalysis is as shown. It showed a blood of 3+, leukocytes 2+, and bacteria 2+ as well. His creatinine had improved from his previous week's creatinine of 169 to 149 micromoles. His white cells and neutrophils are normal, and because of this, pyuria and bacteriuria, a CRP was requested, and the CRP was within normal range, just as the white cell count was. So this patient has an asymptomatic UTI. So the question that came up was, does he need treatment? And if he does need treatment, which antibiotic should he be started on? Remember that he is 5 weeks post-transplant. And if we do opt to treat him, for how long should he receive the treatment? And after the treatment, does he require prophylaxis? So I'm just going to give you the updates about this patient. So 2 days later, he was started on an oral antibiotic, Septrin, and 2 days down the line, when we got back his cultures, he came back, and now he was having dysuria, chills, bilateral frontal headaches, and had some mild diarrhea. Now his laboratory results show that the CRP of 128, his creatinine had gone up to 158, and his urine cultures had grown E. coli, which was susceptible only to meropenem, amikacin, and gentamicin, showing that it was an MDR E. coli. So he was admitted and started on intravenous meropenem, and his symptoms improved quite significantly. Lab results show that his CRP was coming down. His initial creatinine went up to 175. Subsequently, his CRP normalized, and his creatinine also went back to his baseline of 134 micromoles per liter. So this is a classic case of what we tend to see in patients who have been transplanted, and our kidney transplant patients actually have a very high tendency of developing urinary tract infections. So when you look at the causes of mortality in kidney transplant patients, this is an old slide of 1998 data. It showed that infection was the second most common cause of mortality in kidney transplant patients, and it was following cardiovascular disease. More than a decade down the line, this is basically data for 2012, which shows that, again, infections are still the second most common causes of death in organ transplant recipients 10 years after transplantation. So nothing much has basically changed. Okay? If you look at the acute rejection rates, the acute rejection rates have significantly improved from the 1990s to now, whereby the acute rejection rates in the 1990s was more than 50%, and currently the acute rejection rates are less than 10% in most of the centers worldwide. However, the long-term outcome still remains a challenge in kidney transplantation, as you can see from his aunt's data. And you can see that as the years go on, the rate of graft survival tends to go down exponentially. So the question is, why is that so? Why hasn't improved early graft survival resulted in better late graft survival? So one of the points is immunosuppression may have early benefits, but late adverse effects on graft survival, because it does tend to cause viral infections like BK viral nephropathy, cytomegalovirus infections can occur later on as well. There are other late infections, the aspect of malignancies, and of course cardiovascular disease play a significant part in reducing graft survival. The late graft survival may also occur via mechanisms that are unrelated to the immune injury. So, of course, CNI toxicity is one of them. Chronic CNI use can lead to CNI toxicity, which can lead to graft failure. Recurrence of the disease within the graft can also cause it as well. The immune suppression may become inadequate later because of non-adherence and of the minimization regimes, like what happens most commonly as a cause of chronic antibody-mediated rejection is non-adherence. However, we are going to focus more on infections. So you look at infections in the immunosuppressed patients, we have to remember that because of the immunosuppression, the inflammatory response may be attenuated. So the typical signs and symptoms of the infection may not be present, like what happened in our patient. He did not present initially with the dysuria or the increased frequency. There also may be decreased sensitivity of your serological and radiological tests. Okay. However, now when the infection is diagnosed most commonly, it is already an established infection, and the results of the established infection may be quite devastating. One is that it leads to significant morbidity. The mortality of these infections are quite high. The hospital stay is quite prolonged for these patients, and a lot of these patients end up developing sepsis and septic shock. Remember that treatment may also have more toxicities. For example, in our setup where TB is very prevalent, the use of rifampicin may decrease your CNIs, and the reduction in your CNIs, especially in setups where you're not able to regularly monitor your CNI drug levels, can lead to graft rejection. Use of erythromycin and your antifungals tend to, because these are enzyme inhibitors, tend to increase your calcineurin inhibitors levels. And this can lead to CNI toxicity, again, which can damage the graft. There's also the synergistic nephrotoxicity of the various antimicrobial agents and antifungal agents. For example, aminoglycosides and high-dose cotrimoxazole, especially if the patients now develop MDR microorganisms, and at the same time also require antifungal treatments as well. And this can lead to significant nephrotoxicity as well. So the infections in transplant recipients is as a result of the net state of immune suppression, which I'm going to talk about, as well as epidemiological exposure that the patient has been exposed to. So when we are looking at our transplant patients, we know that our transplant patients basically are given prophylaxis. In a lot of centers, there's the cotrimoxazole or the septin prophylaxis that is given. In some centers, there's isoniazid prophylaxis that is given. A lot of centers are now giving induction therapy routinely for all the transplants. The low-risk transplant patients are getting basiliximab or IL-2 receptor antagonists induction, while the high-risk patients are getting lymphocyte depleting agents like ATG. Now, when you give widespread prophylaxis, there's always a risk of drug resistance. More potent immunosuppression will basically suppress your immunity, and it will modify the presentation by the pathogen. So the symptoms may be diminished. The timing may not be as what we would expect as what the textbooks tell us. And the spectrum of disease as well from the known pathogen may be very different, and it may be more lethal. When you talk about the net state of immune deficiency, we're basically looking at the immunosuppression, the current immunosuppression that the patient is on, and the past immunosuppression that the patient was exposed to. Like, for example, if a patient has had lupus, the patient has been given rituximab previously, the patient has been put on steroids, the patient has been exposed to MMF as well. So it's had chronic immunosuppression, which may play a part in a state of immune deficiency as well. The prior therapies, as we talked about, the patient has been given any chemotherapy. The mucocutaneous barrier integrity, like a lot of patients who come out from theater they have central venous lines, and I don't know where it is carved in stone or the tablet that all patients who are transplant recipients are supposed to be put for a central venous catheter intra-op. In my center, we had to really put our foot down and say we don't want anybody to be put for the central venous catheters unless it is run through the transplant physicians. Neutropenia and lymphopenia, especially because of our induction agents and our immunosuppressive agents. Underlying immune deficiencies like lupus, metabolic conditions, like if the patient is very uremic, the patient is malnourished, patient has got pre-existing diabetes like our patient had, patient has cirrhosis, viral co-infections, especially cytomegalovirus, which has been known to reduce immunity and predispose you to other infections. And of course, the risk assessment during the transplantation as well. So who has a greater infectious risk? Those patients who've been given induction therapy, especially the lymphocyte depleting agents, patients who've been on high-dose steroids, and I'm sure Professor Paget is going to touch on that, because he had carried out a study which showed that if you don't taper down your steroids, you are at a high risk of developing cytomegalovirus. Patients who have received plasmapheresis, patients who are at a high rejection risk, especially those who have got high HLA mismatches, early graft rejections, graft dysfunction, and if the patient has active or latent, the recipient, if he has active or latent infection, or if the donor had active or latent infection like TB, and this has been passed on to the recipient. If the surgery was complex and there were technical complications, there was an anastomotic leak or bleeding, or the wound became infected, if the patient required prolonged intubation, and the presence of surgical, vascular, or catheters like the urinary catheters. Patients who have got a lower infectious risk include those who have a very good HLA match, meaning that you're not going to give the lymphocyte depleting agents, a technically successful surgery, good graft function immediately post-surgery, appropriate surgical prophylaxis, effective antiviral prophylaxis and PCP prophylaxis, and appropriate vaccinations pre-transplant. So this basically lowers significantly your infectious risk. And this is why it is very important that for patients who are being prepped for transplant, those are in stage 4 CKD or even 3B, they should be given the appropriate vaccinations. We need to remember that as the patients progress down the stage of CKD, even the take of the vaccines is not very good. Okay. If you look at the epidemiological exposure, as we talked about, the epidemiological exposure can be from infection that can be derived from the donor, things like latent TB, active TB, or active infections, which can be missed out. Especially, this is more so, especially in disease donation programs. Infections can also be recipient-derived as well. So, for example, if a recipient has latent TB, which is very common in sub-Saharan Africa as well as in the Asian continents as well. And this is why it is important now to come up with protocols that we look at whether we do need to test for latent TB. I mean, we need to look at the cost versus the benefit in terms of doing that, and I'm going to touch on that briefly. There's also the aspect of community-acquired infections. Remember that these patients do tend to get community-acquired infections, which is slightly more than as compared to the non-transplant patients. Nosocomial infections, especially the first 2 months or the first month after surgery, is very, very common as well. And these are normally related to your surgical site infections or to the catheter-related infections. Okay. So if you look at this cartoon about the baseline and acquired determinants of infection post solid organ transplants. So the recipient's health condition accounts for the risk of infections throughout the post-transplant period, whether it is early onset infections or it is late onset infections. So the age of the recipient, whether the patient is malnourished or not, whether the patient has pre-existing diabetes, his or her prior immune status, and of course, chronic organ dysfunctions. Early onset infections are related to acquired defense alterations through either your surgical procedures or your intravenous catheters and drains, and of course, endotracheal intubation. And they're also related to your immunosuppression, especially your induction therapies. The late onset infections are mostly related to your intensity of your immunosuppressive regimens, which can now lead to reactivation of your cytomegalovirus, or whether these patients have chronic wounds or long-term invasive devices which lead to breakthrough of your natural barriers. If you look at the usual sequence of infections post-transplant, in the first 1 month post-kidney transplant, you can see that most commonly it is your conventional or your nosocomial infections. Okay, like your viral infection, it is your herpes simplex virus. For fungal, it is mainly your candida. For bacterial, it is mainly wound infections and catheter-related infections. Pneumonia can set in at any point in time, especially the ventilator-associated infections or nosocomial pneumonias if the patient was on the ventilator. Okay. From 1 to 6 months, it is mainly your unconventional or your opportunistic infections. And after 6 months, it becomes your community-acquired or your persistent infections. Now, this is basically for all the microorganisms. When you look at the chronology of bacterial infections post-solid organ transplant, the first 2 months, it's mostly your non-opportunistic bacterial infections, like your surgical site infections, urinary tract infections, catheter-related infections, and Clostridium difficile infections as well play an important role. Urinary tract infections, especially in renal transplant recipients, can occur at any time post-transplant. It can be early or even later on. As you can see in our patient, it was quite early in the 5th week of his transplant. Now, if you look at opportunistic infections like nocardia, listeria, and tuberculosis, these tend to occur most commonly after your 2nd month of your kidney transplantation, when your immunosuppressive state is quite high. When you look at the risk factors for early post-operative infection, the risk factors that predispose to early post-operative infections in recipients of organ transplantation can be categorized as being those factors that are present pre-transplant, like recipient factors and your donor factors. Recipient factors are basically include your underlying illnesses, especially the severity of the organ failure, or if the patient has had surgery before transplant, or they can be donor factors, infections within the organs or the blood vessels, or if the patient has bacteremia, the donor has bacteremia which can be transmitted onto the recipient. Now, the other category is basically those that are secondary to intraoperative or post-transplantation factors. So the intraoperative are the technical issues of what we talked about, either your anastomosis, the prolonged operative time, the surgical complications like bleeding, or in kidney transplant recipients with cycloureteric reflux, can all lead to early post-operative infections. Now, bacterial infections post-transplant, the incidence rate has been estimated to be 23.2 cases per 100 transplant years in North America. And it also depends on the organ that has been, or the site that is involved in the surgery. So solid organ transplants involving intra-abdominal surgery has the highest rate of bacterial infections. This includes liver transplants, pancreatic transplants, or intestinal transplants. Now, remember that bacterial infections post-transplant can appear during all post-transplant periods, and they're a major cause of morbidity and mortality. And most common infections are those that are related to the urinary tract. Kidney transplant recipients are at an increased risk for reactivation of TB as well, and other opportunistic infections like nocardia and listeria. The first 2 months post-transplant is when the risk of bacterial infection is very high. One is because of the surgical aggression that is inherent during the transplant procedure. And 2 is because of the invasive procedures and the use of indwelling catheters like endotracheal intubation, the use of CVC lines. Again, I can't emphasize that enough for our fellows out there, that not all patients, not all transplant recipients during the surgery need to have a CVC line. CVC lines are practically useless. I know initially they used to be used for hemodynamic monitoring, but that has been thrown out of the window. And urinary catheterization. So it is important to have a protocol whereby you need to have a timeline after which the urinary catheter, without a consultation with your transplant surgeon, can be safely removed after a kidney transplant. Okay. The risk of opportunistic bacterial infection is quite low during the first 2 months, and this is mainly because of the net state of immune suppression is low during the first 2 months, but that tends to rise progressively from the 2nd month to the 6th month. Now, of importance is that in recent years, there has been an emergence of multi-drug resistant pathogens, mostly from hospital-acquired infections. Now, if you look at the history of our patient, he basically had an MDR pathogen in the urine, MDR E. coli, which was only sensitive to the carbapenem, the 2nd generation carbapenems, as well as the aminoglycosides. So it is important to keep that in mind when we are faced with patients who come in with suspected infections. So when you look at the source of infections, the bacterial source of infections, during the first month, the most relevant sources of bacterial infections include your intravascular catheters, the urinary indwelling catheters, the surgical sites, and ventilator-associated infections for those patients who remain on the ventilator post-operatively. After the 2nd month, most common sources or sites of infection include your urinary tract infections, community-acquired pneumonias, and opportunistic infections, okay, like nocardia. Urinary tract infections are the most frequent site of infections post-kidney transplant. Some studies have quoted a prevalence of between 23% to 75%. And this has been associated with significant morbidity and associated increased mortality and acute graft dysfunction. Whether a urinary tract infection will lead to chronic graft dysfunction is still debatable, especially if it is treated early. But we do know that any infection, especially urinary tract infections post-kidney transplant, have been associated with acute graft dysfunction as what happened with our patient. Although it is most commonly seen in the early post-transplant period, it can occur at any time following the kidney transplant. Of note is that patients who have polycystic kidney disease and who are transplanted are at a higher risk of developing recurrent UTIs post-kidney transplant. What are the risk factors for urinary tract infections post-kidney transplant? So they include pre-transplant diabetes, like our patient had got type 1 diabetes, previous history of recurrent UTI, so it's always very important to get that history from the patient, placement of ureteric stents, like what our patient had. Female genders normally do tend to get frequent urinary tract infections. So the same applies here in post-transplant as well. Prolonged urinary tract catheterization, I can't overemphasize it. You have to have a timeline for when you can remove your urinary catheters. Any urinary tract abnormalities, so these have to be carefully assessed prior to the transplant. Acute rejection and use of lymphocyte depleting induction therapy, of course, we know that now this predisposes you to infections generally. If you look at the most common etiologic agents for urinary tract infection, these include E. coli and Klebsiella species. Our patient had MDR E. coli, and this is followed now by Pseudomonas aeruginosa and your Enterococcus species as well. Urinary tract infections post-kidney transplant are difficult to recognize. The patients may not be symptomatic. Okay, the usual symptoms are not present always due to the disruption of the usual neural pathways. However, the standard definitions of urinary tract infection reflect those used in non-transplant patients, and these include pyuria and bacteriuria. It's very important to perform susceptibility testing for urinary tract isolates due to the increasing reports of MDR pathogens. The normal IDSA guidelines recommend just treatment for the non-complicated urinary tract infections. Remember, post-transplant, all of these infections are considered to be complicated urinary tract infections, and it's important to send for culture and sensitivity. Radiological tests do play an important part and role. So ultrasound and CT imaging may confirm the diagnosis of pyelonephritis and may reveal structural abnormalities as well. The treatment should be based on the suspected site of infection, whether it is the lower tract, urinary tract, or the upper urinary tract. However, this can be difficult given the atypical presentation of the infection. Shorter antibiotic duration of 5 to 7 days is recommended for lower tract infections. Pyelonephritis should be treated for 14 days. Relapsing or recurrent infections with the same organism should be treated for more prolonged periods of between 4 to 6 weeks. So the choice of antimicrobial should consider the potential for antibiotic resistance, which is very important, the severity of the illness, and of course, very importantly, is your drug-to-drug interactions, especially with your calcineurin inhibitors. Remember, we talked about your macrolides, which are enzyme inhibitors. Intravenous agents should be initiated for more severe infections, and patients with frequent or persistent urinary tract infections should be assessed for structural abnormalities so that this can be corrected surgically to prevent the risk of recurrent infections. Asymptomatic bacterial infection or bacteriuria is a significant area of controversy. Initially, it used to be thought that it has to be treated, but now there was very many studies and a Cochrane review showed that there's no evidence that treatment resulted in any benefit or prevented the progression to fulminant or full-blown UTI. And current guidelines don't recommend treating asymptomatic bacterial infections because there's a risk of developing antimicrobial resistance. And of course, there's always a risk of developing Clostridium difficile infections. However, these should be taken on a case-to-case basis based on the prior history of the patient as well. Okay. The other very difficult infection or an infection that is very important is tuberculosis, especially in our setup in sub-Saharan Africa. Among solid organ transplants, the incidence of TB post-transplant is 20 to 74 times more frequent than in the general population. The incidence varies depending on the local endemicity of TB, with low endemic regions, especially in Western Europe and in Northern America, reporting rates of between 0.5% to 6.4%. Higher endemic regions report a rate as high as 15%. And it's very important to remember that it is associated with high morbidity and a very high mortality. A lot of times TB is missed, even in those patients who have not been transplanted, and more so in patients post-transplant, okay? And we tend to get it when it is already an established infection, whereby treatment is very challenging, and of course, the mortality is very, very high. The risk factors for TB post-transplant, again, epidemiological factors, as I said, that especially in sub-Saharan Africa, where TB is quite endemic, so the risk is quite high. Patient factors, those who have got pre-existing diabetes, patients with chronic liver disease, patients who are malnourished, which is very common in sub-Saharan Africa, past history of untreated TB, and co-infection with hepatitis C also predisposes you for TB infections as well. Then the transplant-related factors. The organ transplanted, so of course, lung transplants are associated with a much higher risk of TB post-transplant. Use of induction agents like T-cell depleting agents predisposes you to TB post-transplant, as well as anti-rejection treatment, because of course your immunosuppression tends to go up quite significantly as well. TB is very difficult to diagnose and treat post-transplant. It's very important to have a high index of suspicion in high endemic areas when a patient presents with features of an infection, especially when there's recurrent infection. You're not isolating any microorganism, like when you have sterile pyuria and the patient is symptomatic, we need to start thinking about TB of the urinary tract, okay? I had a patient who had an abscess on the thumb, and it turned out to be because of TB. The patient had been on treatment, on follow-up by another physician for almost 4 weeks before the patient sought a second opinion, and it actually was TB. So TB can present in myriads of ways. So we need to be very cognizant of that fact, and we need to have a very high index of suspicion. Remember, when you're starting treatment for TB in post-transplant patients, the drug-to-drug interactions, rifampicin and CNI interactions. I mean, rifampicin is an enzyme inducer, and it significantly lowers your CNI drug levels. So you have to monitor that very closely. The duration of treatment, it follows the standard guidelines for the non-transplanted patients, because we don't have much data about that. Now, when you look at prevention of bacterial infections, it is always important to evaluate the infection risk pre-transplant, assess both the donor and the recipient, especially when you're doing living transplants, okay? Assess the recipient's work and home environment, including the prior living arrangements, personal contacts, if they've been in contact with anybody with TB, then you need to start actively looking for latent TB. What pets do they have? What hobbies do they have? Okay. In TB endemic areas, it is important to evaluate patients for active or latent TB. Very important to take a history and examination to assess if the patient is active TB. A chest X-ray becomes important as well. Your tuberculin test and your IGRA, interferon gamma release assay, have less sensitivity in CKD patients. And your IGRA test, especially here in Kenya, is very, very expensive. It costs almost $250 US. So I'm saying that when you look at the risk versus the benefit of doing it. But again, it all depends on the patient in front of you. Okay? If you have diagnosed latent TB prior to transplant, it is important to treat it. Okay? And there are various treatment regimens that are available. Either you can use rifampicin monotherapy, or you can use this for 4 months, or you can use isoniazid and rifampicin for 3 months, or you can use isoniazid and rifampicin, which is given weekly for 3 months. In areas with high TB prevalence, you can give isoniazid prophylaxis for 6 months and then subsequently stop. But of course, you have to remember about liver toxicity, like what happened with our patients. There's always a risk of developing isoniazid resistance, but so far not come across any reports of isoniazid resistance because of isoniazid prophylaxis. And as I mentioned, we have to monitor your LFTs if the patient is on isoniazid prophylaxis. Just my last slide about management of immunosuppressive drugs. When the patient develops sepsis or solid organ transplant, you have to evaluate the risk of graft rejection. If it is a very high immunological risk, you have to keep your immunosuppressive drugs. If it's a low immunological risk, then you can withdraw your antimetabolite, okay? And you can replace your prednisolone with hydrocortisone if the patient is intubated or can't take orally, and keep your calcineurin inhibitors. Remember to always look at your drug-to-drug interactions. Some patients do require renal replacement therapy when they get acute graft dysfunction, or they develop severe acidosis, or for whatever reason. And remember that none of these drugs that I mentioned are removed by renal replacement therapy. So I end my presentation there, and thank you very much. What do you, Professor?
Thank you, Sen, for this excellent presentation. I think we'll move now to the next one, introduced by Professor Gloria Ashutantan, and we'll discuss after lectures.
Thank you very much, Abdul, and want to thank Dr. Baga for the great lecture. So it's my pleasure to introduce Professor Graham Page, who is currently the head of the renal division at Charlotte Maxeke Johannesburg Academic Hospital. His research interests include viral infections in renal disease, and is currently undertaking his PhD in these potential aspects of idiopathic nephrotic syndrome. He has been president of South African Society and so many other things. So it is really my pleasure to invite you to give your talk, Dr. Graham.
Thank you very much. I just want to confirm you can all hear me.
Yes, we can.
All right, well, I'll G things up. So we're looking, I mean, obviously there's many different sorts of viruses that one can be involved in. So I've chosen a few to look through, the important ones perhaps relevant to transplantation. You know, viruses are not something you'd hopefully acquire post-transplant. So a lot of the talk is on, you know, what do you do with a patient who has a viral infection? What are your options? What can you do? Okay, so essentially, it's just important to understand that RNA viruses replicate within the cytoplasm, and DNA viruses and retroviruses tend to replicate in the nucleus of the host cell and then usually cause the cell to lyse. And this allows the virus to infect adjacent or distant uninfected cells via the bloodstream or neuronal route, which then ultimately leads to a clinical illness. So usually with intact innate immunity, largely based on the interferons, and adaptive immunity, which, as we know, is often a T-cell process, most infections are controlled or eliminated, and, you know, thank goodness, otherwise we'd all be dead. So certain types of viruses, though, can establish persistent infections in immunocompetent hosts, and which can then be divided into chronic and latent infections. And this is important for the different types of viruses. So certain ongoing viral replication and shredding can be documented and seen in chronic viral infections, and good examples of that are hepatitis B and C, while maintenance of the viral genome without replication can be seen in latent viral infections, and particularly things like the herpes viruses and polyomaviruses are very good at this. So latency is then achieved when the genome of the virus actually remains in the cell, and these viruses actually subvert the apoptotic pathways. There's not enough time to go really into it, and are then not cleared by the host immune system and cause problems. So epidemiologically, overall cytomegalovirus and BK virus are probably the most common and troublesome viruses we face in transplant. And then it sort of depends a little bit where you are in the world. So hepatitis B and C and things like HIV are endemic in certain parts of the world, and particularly in our setting, we have a lot to deal with hepatitis B, C, and HIV. So we'll go through them, just perhaps somewhat of a summary. So cytomegalovirus, it's endemic in developing parts of the world, and especially if you've transfused ESRD patients. And we know that, for example, in South Africa, cytomegalovirus seropositivity is almost 100% in blood donors. So it's a big problem. And it's a virus that has both direct and indirect effects. The direct effects, where you get a viral illness, and this is not seen so much anymore, but if you happen to transplant or acquire CMV post-transplant, you will get quite sick. And this can be anything from pneumonitis to just simple flu-like illness, etc. The indirect effects are very interesting in terms of what the virus does, in that it actually can injure the graft. And as the previous speaker pointed out, it actually enhances immunosuppression and allows other opportunistic infections, as well as, frankly, certainly in the studies we did, things like UTIs become important. All right. And really what is now recommended, a lot of the guidelines, is that if you're doing higher risk patients, so in other words, if you've got donor-recipient mismatch, the recipient is negative, has never seen the virus, they are obviously at high risk. Or if you're using T-cell depleting agents like the thymoglobulins for induction, you should probably give universal prophylaxis. This is, of course, depending on whether you can afford it or not. And patients with low or intermediate risk you can just do preemptive approach. So if you're able to do viral loads, you do it once a week for 3 months or whenever you can. Certainly in our hospital, a CMV viral load can take up to 3 weeks, so it's not particularly helpful. And essentially, when you look at the strategies, the preemptive strategy is probably felt to be less costly than the antiviral drugs. You do, importantly, maybe you're not exposed to prophylaxis, and this limits your opportunity to become resistant to the virus, although this is not that common. And then you only treat when the viral replication is detected. The prophylactic strategy is you just start treatment. There are some issues with late CMV disease, and there is certainly an element of toxicity from the antivirals, especially when in combination with antimetabolites like MMF. So, and of course, the drug costs a lot of money. Happily, in our country, there is a generic becoming available for the prophylaxis we use. So talking about Epstein-Barr virus, again, this is a virus, one of the herpes group viruses. It can vary from anything from an asymptomatic to uncomplicated infectious mononucleosis, hepatitis, pneumonitis, lung mass lymphadenopathy, hepatosplenomegaly, and eventually to post-transplant proliferative disease. It has the lowest incidence in kidney transplant overall. And importantly, again, similar to CMV, certainly the vast majority of South Africans, for example, have been exposed to EBV and thankfully are EBV seropositive. And this is very important in particularly certain types of immunosuppression, the newer CNI avoidance agents, that it's very important that you are EBV exposed and you can't use these drugs if you've never seen EBV, because you will get very, very sick. So the preventative strategies are not absolutely defined for EBV, but a little bit later I'll talk about how we can, we have a sort of one drug fixes everything approach. So the nightmare virus. The nightmare virus is BK virus. So in the modern era where we're using things like mycophenolate and tacrolimus routinely, this has become a problem certainly for us. It's a very difficult agent to deal with. So after BK infection, which is sometimes acquired in sort of childhood or early adulthood, the BK virus remains latent. It's a virus that achieves latency and basically does nothing until you immunosuppress the patient. And then it can cause, so the groups of patients that I've really ever seen it in is obviously solid organ transplants, especially renal transplants, but also in bone marrow transplant recipients, this virus can become quite a nightmare. So its main problem is that it causes hemorrhagic cystitis, but as we know, often and that's more in sort of bone marrow transplant patients, but in solid organ transplant patients, what it often causes is this kind of graft dysfunction, and now you're not sure what's causing what. And you can, so screening for BK virus by PCR for viruria was in vogue, but in actual fact, because it doesn't really correlate nicely with actual nephropathy, we've largely abandoned it. And also we could never get our labs to get it right. So what we tend to do is you do a BK viral load, look for the DNA, and, you know, anything above sort of 1,000 copies per mil, or at least some labs reported as 10,000 copies per mil, is indicative of that you've probably got BK viral disease. And whether or not you can biopsy the patient to demonstrate virus, that does certainly clinch the diagnosis. What do you do about it? So generally speaking, the principal goal is to reduce immunosuppression. The problem is this is a virus that often pokes its head out in the first month post-transplant. So you're faced with a decision to sort of withdraw, and there's various opinions as to whether or not you should withdraw mycophenolate first or tacrolimus first. It's interesting that maybe, I know that the literature says mycophenolate, but it's really a virus that has emerged in the tacrolimus era. So it would sort of, to me, make a bit sense that maybe reduce that first. You may replace the tacrolimus with cyclosporin, or you may completely withdraw CNIs. Antiviral treatment is controversial. Cidofovir is effective. It's a very expensive drug to acquire. You need to have access to probenecid to give the drug. It is a drug that is nephrotoxic. It's difficult. Some people have used leflunomide. You know, as you might be aware, it's a drug that has hepatotoxicity if you have renal dysfunction, like a single kidney, low GFR. So it's given at a loading dose of 100 milligrams for 3 days, and then a maintenance dose, often about 20 milligrams a day. So basically, studies of leflunomide with reduced immunosuppression showed that about 42 to 71% cleared the viremia, and 60% of them required leflunomide at least 60 milligrams a day. But that is probably an issue with the liver, I can guarantee you, and that's a case series. Quinolones were in vogue as well. Levofloxacin was actually failed as an agent in randomized controlled trials. Case reports have been discussed for ciprofloxacin, but if you're aware of the black box warning for quinolones certainly in patients on steroids, it's not a drug that you would really use easily. You know, you tend to sort of rupture your Achilles, your aorta, all sorts of horrible things happen to you. So a drug that does actually show potential is IVIG. So if you use 0.2 to, 2 grams per kilo is huge. Remember that polygam or IVIG does have nephrotoxicity, but there was a study for transplant patients who did not respond to 8 weeks of the adjusted immunosuppression and leflunomide, and that 90% of the patients actually cleared the viremia, and 96% of patients had graft survival beyond 12 months. What we tend to do is we tend to play this sort of ping pong game between keeping the viral load lowish and trying to avoid rejection. Very often it's quite interesting. The patients will develop rejection. You upgrade the immunosuppression a little bit, and then basically sometimes the virus still remains latent. So we're not 100% sure what to do with it. The baseline principle is, though, that you do need to reduce the drug, but rejection definitely, certainly cellular rejection does occur. Right. Hepatitis A virus, again, it's mostly seen in our sort of neck of the woods, developing countries. Obviously, acquiring hepatitis, we prefer that patients are vaccinated, or at least have maybe IgG from natural or wild acquisition, but it is an agent that can induce a fulminant hepatitis. Thankfully, in endemic areas, quite a few of the hemodialysis patients have positive anti-Hep A IgG. Definitely anyone who is eligible for a kidney transplant who has chronic liver disease or risk factors for acquiring hepatitis A should be tested, and a vaccine should be offered to those with a negative result. And, you know, it's usually given it's berry-globin in our setting, but it should be given in 2 doses at 6 months apart. Hepatitis B, as we know, it's the terror of dialysis units, super infectious. Reactivation of the Hep B after transplantation occurs in up to 94% of patients with positive surface antigen. And in actual fact, it's felt that transplanting somebody with positive surface antigen is borderline unethical, to be honest. There is some risk, of course, of reactivation in patients who are core antigen positive, but generally these should be avoided. We know that KDIGO, etc., suggests that we vaccinate all dialysis patients who are Hep B surface antibody negative. And as the previous speaker pointed out, the earlier you start these vaccines, the better. So we encounter a lot of patients who are coming back after transplant, and really you find that it's very difficult to get them to seroconvert. So chronic infection should be evaluated for treatment, and those who do not meet treatment criteria should receive either tenofovir or entecavir after transplantation. So an interesting one is using organs from donors with anti-hepatitis B core. What is thought is that antiviral prophylaxis is not required if the patients have anti-HB surface antibody titers above 10 units per liter. But you can consider 1 year's worth of 3TC prophylaxis in recipients with negative anti-HB surface antibody. Donors with PERV, so certainly we've had actually a couple of weeks ago an offer of a donor with a positive surface antigen. We still declined it. Consensus guidelines still recommend indefinite antiviral prophylaxis in all recipients, regardless of immune status. And you should give Hep B immune globulin in recipients with hepatitis surface antibodies under 100 units per liter. We had our doubts. What is also perhaps useful in this situation is to actually see what the viral load of the potential donor is and make a decision. But if you don't have access to hepatology and antivirals, probably still, for most of us, avoid patients who are surface antigen positive. Hepatitis C, it depends a little bit where you are in the world. So the Far East, Asia, quite high rates. We don't have a lot in South Africa. So the seroprevalence varies. As we know, lots of people, you do certainly get false negative hepatitis C antibody results. And you should really, before you do anything else, check the viral load, genotype the virus, and then do an investigation for hepatic fibrosis. We use FibroScan. You might consider doing a liver biopsy. Of course, that's invasive. So Metavir scores F0 to F2 don't require treatment before listing, whereas those with bridging fibrosis and compensated cirrhosis should be treated and achieve SVR. We're fortunate, I don't know what everyone else's experience is, but we've now managed to acquire antivirals, not Pegasus or pegylated interferon, which is a very difficult drug to use, lots of neuropsychiatric side effects. And, you know, these drugs really do work. They've got horrendous names. Anyway, but these drugs, you know, 3 months treatment, greater than 90% sustained viral response. So it really is a situation now where using the direct antivirals, you can achieve pretty much cure in all these patients. So it's becoming less of a problem. And that's why we prefer these patients are treated before transplant, because there's significant drug interactions between certainly semaprevir and cyclosporin, and paritaprevir, ritonavir, and ombetacivir, dacibavir. They've got horrible names, these drugs anyway, and cyclosporin or tacrolimus. Organs from hepatitis C positive donors could be considered for hepatitis C positive recipients. There is a little bit of literature on using hepatitis C donors in situations to hepatitis C negative recipients, especially when you have antivirals. There might be some publication bias in terms of the adverse event rates. So it's something you could consider, but of course you will need to give the recipient antivirals. The other viruses, hepatitis D and E, we don't generally test for hepatitis D. And basically, if you control hepatitis B, there seems to be an appropriate practice in managing hepatitis D infection. Hepatitis E generally has a low prevalence. It's a little bit higher in certain areas, France and Thailand, and it can be associated with worsening of chronic liver disease. Ribavirin is promising as a treatment option, but of course, you remember if you're giving it to patients with abnormal renal function, hemolysis is a big issue. And of course, using pig interferon post-transplant will certainly wake up your T cell responses, and there's quite a high rate of rejection. Just to say a little bit about HIV, I think certainly in Africa, we have vast experience in managing patients with HIV. We have excellent antivirals now that work very well. So it's no longer really a barrier to transplantation. Just some interesting things that were done in South Africa or started in South Africa and is now becoming more mainstream. And this was the concept of using HIV positive to HIV positive donors and recipients. This was pioneered Elmi Muller at Cape Town. And essentially, this led to changes in the US, etc. And it's now really taken as it's fine to do. Certainly, when you are using things like dolutegravir, you don't really have problems with viral resistance. An interesting one, what about HIV positive donors? And this is, you know, could this be done in someone who's negative and then be given antivirals afterwards? This has been performed. It's not certainly mainstream, but it has been relatively successful. Certainly at Donald Gordon, this was a liver patient. The child, it was published, the child was HIV negative, mum was positive. The child had severe hepatic dysfunction, required an urgent transplant. And, you know, to date, the virus is not detectable in the donor. It's just important, perhaps, to think about in our situation. These studies have, one or two have been done in Caucasian individuals, as you know, who don't have APOL1 variant issues, and what would happen if you put in a kidney to someone who's maybe sort of homozygous for APOL1 deletions, and what would happen to the graft, etc. So it is something that should be done as a sort of a clinical study. Just, you know, COVID was a big thing. It's still a little bit around. I'm not sure what everyone else's experience was. But as we know that at the time of the height of the pandemic, it depended on what subtype you got. That transplant patients who acquired COVID got particularly ill. It's important to remember now that really only remdesivir and steroids are effective in treating COVID. So if you do look, hopefully most people in the world, or as many as possible, are vaccinated. Our experience with COVID now is really, thankfully, that it's pretty much a non-event. And then importantly, patients, there was a lot of debate, there was a lot of arguing, to be honest, about whether we shouldn't be transplanting if there were COVID outbreaks. This may become important with the next whatever outbreak we're going to get. Yeah, unfortunately, I saw today there was a article on monkeypox. I don't really have any slides on it, but one can imagine being immunosuppressed post-transplant, that would be an issue. But essentially, patients on the waiting list still did worse than those who were transplanted. So it is something to think about. And the herpes group viruses, these are also common, often not a big issue, more sort of mucocutaneous disease, but can cause organ disease. Acyclovir is effective. Remember to dose adjust it for GFR, especially if used intravenously. So crystalline nephropathy is a real problem if you use the IV acyclovir and infuse it quickly in a high dose. Ganciclovir, foscarnet are effective, but cost and toxicity are important, and the drugs are not easy to get. About 90% of adult organ transplant recipients are zoster seropositive, and thus reactivation will tend to cause zoster. The remaining 10% are seronegative, and they get risk of primary infection. So the problem is primary infection with zoster can cause DRC, hepatitis, and pneumonitis, can be quite severe. Importantly to remember is that the vaccine for zoster, it's one of those vaccines that's live, therefore only pre-transplant. If you're naive and you're exposed, you need to get zoster globulin, and that's important. We tend to use valganciclovir for prophylaxis. And what's nice about it is, frankly, it gives prophylaxis for the herpes group viruses. So it will prophylax EBV, herpes simplex, and varicella zoster. So a sort of all-in-one, which really it should, because it is quite expensive. So one of the big things, just to, as we almost finish, is that viruses are important in tumorigenesis in kidney transplant recipients. And the risk of cancer is multifactorial and can be attributed to viruses, immunosuppression, and altered cellular immunity. I haven't gone a lot into this, but certainly one of the big ones to highlight is papillomavirus. So hopefully many countries in the world have access to Gardasil. Certainly we are trying to immunize women who have abnormal pap smears, even though they've had either LETs or cone biopsies, but they've been exposed to HPV. There's some evidence that using Gardasil will actually prevent progression to cancer of the cervix. And it's important to remember that one must keep an eye out for cancers in these patients. They don't generally get more of the classic solid organ malignancies like we see, but certainly viral-driven oncogenic viruses are important. As I said, it's a bit of a cook's tour. So what's important is that renal transplant recipients can acquire or reactivate viral infections, especially with immunosuppression. And the more immunosuppressive your immunosuppression is, the more viral problems you're potentially going to get. Viral replication itself can manifest as organ or life-threatening disease. I certainly didn't have time to go through all of them. I mean, I've had to deal with adeno and things like that. That can be quite nasty. Be aware of viruses endemic to your area. And as was highlighted in the talk before, trying to vaccinate pre-transplant as much as possible is what we should do. There are excellent guidelines on what vaccines are safe to use. But again, sometimes we can't always access everything, so we do the best we can. Thank you all.
Thank you very much, Professor Paget, for that excellent talk. Please just keep your questions coming. We would have them at the end of the talks. So I'll now hand over to Professor Abdul Nyang.
Thank you, Gloria. I will have the pleasure to introduce my dear friend, Professor Fatiu Aragundane. Professor Fatiu is a fellow of West African College of Physicians and immediate past president of Transplant Association of Nigeria, member of Executive Committee and Council of International Society of Nephrology, and chair of the African Regional Board. He was the past secretary and past president of Nigerian Association of Nephrology, and I had the pleasure to be the deputy of Secretary General and Treasury of Professor Fatiu in African Association of Nephrology. He was also chairman examiner of the Faculty of Internal Medicine and member of governing board of NPMCN. Professor Fatiu, please, can you talk about fungal and parasitic infection in kidney transplantation?
Good afternoon, good evening, everybody. Thank you, Abdul, for the introduction. And let me thank the organizers for inviting me. I'll be discussing parasitic and fungal infection in transplant recipients. I do not have any conflict of interest with this presentation. This will be the outline of my talk, as shown on the screen. The typical presentations stroke classification of parasitic or fungal infections. Like we've been told by the two previous speakers, my distinguished co-speakers for this evening, there could be de novo infection, meaning natural infection developing in the transplant recipient. And it's also possible that there could be transmission by a transplanted organ, either via the blood products or either before or after the transplantation into a patient that has not been infected before, a naive patient. And it's also possible there could be recrudescence of latent infections in the previously infected patient. We've been told about that of tuberculosis. You could have the same thing in toxoplasmosis and some other parasitic infections. Now, some other workers classify parasitic infections this way. They looked at those that are extraintestinal, those that are intestinal, protozoa, nematodes, and those that are trematodes and those that are cestodes. For the extraintestinal ones, they talk typically about Leishmania, Babesia, and Toxoplasma. For the intestinal, they are very common in our environment. But in the immunosuppressed, we see a lot of Cryptosporidium and Cyclospora. E. histolytica is common in everybody. However, in the immunosuppressed, you could see florid infections. Giardiasis is also common, Acytospora belli, Microsporidia infections. How about strongyloides, the intestinal nematode? It's also quite common in transplantation. Schistosomiasis is a major one, and Echinococcus granulosus infection is also a major one. I must mention that some of them induce immunological changes. Some of them infect only at the mucosal level. And that's why E. histolytica may not necessarily pose any problem, except if it's not adequately treated. Now, in transplantation, why do they have infection? There's a delicate balance between the need for immunosuppression and the fact that we must ensure graft survival and graft function. If we under-immunosuppress, if we over-immunosuppress, then the patient will be prone to developing infections. Both cell-mediated and humoral immunity will be reduced. So the patient will be prone to developing infection. If we worsen of infections too. Now, what is the distribution of global parasitic nephropathies? We have malaria zone between latitude 14 degrees north and 20 degrees south of the equator. And we have schistosomiasis common across all these zones. In the South American subcontinent, in Africa, particularly in West and East Africa, and in the Asia subcontinent. Of course, we could see that the one that is most common in the Asian subcontinent is the Schistosoma japonicum. P. malariae has been reported in West and Central Africa. I must mention that it's now very, very rare. It's hardly reported now. P. falciparum is seen virtually everywhere, including in the Indian subcontinent. And then we have hydatid cysts, both in West and East Africa and in South America. Filariasis is virtually across all these zones that we mentioned about. But if you look at it, they are mainly in the tropical environment. Why are parasitic infections important in transplant patients? There are geographic areas where parasitic infections are endemic and now very active with different organ transplant programs. So naturally, many more patients will develop parasitic infections. 2, donors and recipients from endemic areas are now referred to transplant centers in other countries. So they may transfer these infections to those countries. Transplant tourism, patients undergo transplantation in parasite endemic areas. Patients go to India subcontinent for transplantation, they come to Nigeria, go to different areas. And of course, there they could then acquire infection because these areas are endemic. Immigrants are equally accepted for organ donation in the developed world. So, and they may have their latent parasitic infections that could flare up with immunosuppression. And we now know that there's leisure tourism now. A transplant patient could desire to go on a visit to Mambila Plateau in north central Nigeria and be exposed to infections in that area, or may decide to go to South Africa. The use of immunosuppressive regimen with little or no antiparasitic activity could also lead to florid infection. Like we do know that some cyclosporin metabolites have antiparasitic activity. So we now shy away from this type of drugs and use some other calcineurin inhibitors or some other classes of drugs. You may increase the potential for developing parasitic infection in these patients. What are the major broad categories that we have, particularly when it involves the immune system? We could have acute renal injury from parasitic infection, we could have physical invasion of the urinary tract, and we could have renal injury caused by host parasite immunological reaction. I've given some examples of the parasites that cause each of them. What happens in parasitic nephropathy in terms of immunology? There's host-parasite interaction, recognition by a major histocompatibility complex, formation of antibodies, antibodies combining with antigen to form immune complexes, either in circulation or in situ in the kidneys, lymphocyte activation and clonal expansion, and release of mediators of inflammation. And of course, all this lead to damage of resident cells in the kidneys. How did this happen? How do we handle parasites in the body? When the parasite gets into the body, of course, this is the parasite antigen that comes in, is sensed by the monocyte. And monocyte releases interleukin 1, 6, and 12 via GM-CSF, and Th1 response secretes interleukin 2 that stimulates the eosinophil. The eosinophil via antibody-dependent cell-mediated cytotoxicity clears the parasites. And so the parasites are cleared off the system. It's also possible that the monocytes will do this stimulation via Th2 response when there's interleukin 5 and 13 are secreted, and this stimulates the eosinophil to do the same thing. Of course, the Th2 response will equally lead to stimulation of the beta cells, and that will lead to production of immunoglobulins, particularly IgM, IgE, IgG, and IgA. And of course, that will lead to formation of circulating immune complexes, which will activate the complement system. And of course, that will also activate the neutrophil to be able to eliminate the parasites. However, these parasites now get entrenched in the system via several ways. One, antigen variability. They could change the antigen from time to time in the host, in which case the ability of the host to mount the response to them may be limited. There could be banding of host cells. There may be binding of host cells to parasite antigen, and that will lead to formation of circulating immune complexes, and of course will trigger inflammation. There could be down regulation of the monocytes, meaning that the response to these parasites could be reduced, in which case the parasite then perpetuates itself, release antigen, and this combines with the antibodies and form immune complexes. There could be antigen excess, a lot of parasites in the system, which will overwhelm the system, overwhelm the ability to eradicate the parasites and induce inflammation. and it could be induction of suppressor T cell clones. Here we could see some of the examples of the parasites that perpetuate some of these evasive mechanisms, like the trypanosoma and plasmodium in antigen variability. And I must say that's why it's been very difficult to develop vaccines for malaria. Now, how do they manifest clinically? They could manifest as asymptomatic proteinuria, acute tubular interstitial nephritis, acute glomerulonephritis, chronic glomerulonephritis, and they may come in renal failure, whether acute or chronic. We'll now look at some of the important ones, because it will be difficult to cover all parasites in these few minutes that I have. Malaria is very common. We know that in the West and East Africa, about 90% of people live in malaria endemic zone. And quite a large population is exposed to malaria, particularly Plasmodium falciparum malaria. It could cause acute kidney injury resulting from acute tubular necrosis, and it could have acute transient reversible glomerulonephritis. And it could also cause chronic, progressive, irreversible glomerulonephritis. But that is usually from quartan malaria nephropathy, which I say is hardly reported these days. It's now very rare. So how do we respond to malaria? Malaria releases its antigen is sensed by the monocytes, which stimulates Th1 response, stimulate the CD8 cells, and stimulate tumor necrosis factor alpha. Both of these stimulate inflammatory reaction within the kidneys. You can equally have TNF alpha stimulating endothelial activation. Like we know, the melanocytes will invade the red blood cells, cause red cell membrane changes that induces cell lysis, and also induces platelet aggregation. All this further worsening inflammation and causing hemodynamic instability. And you could have Th2 response to the monocyte, leading to release of immunoglobulins. As said before, this combines with the antigen to form circulating immune complexes and of course causes immune complex disease. It's also possible in malaria in particular to have florid infections with a lot of Plasmodium falciparum parasitizing the red cells. And you have increased mechanical fragility, endothelial activation and clumping. And you could equally have release of cytokines, reactive oxygen species, all of these leading to impaired tissue perfusion, and of course, acute kidney injury. What about the acute glomerulonephritis? Occurs usually in Plasmodium falciparum infections, but not in the immune host, usually in semi-immune and non-immune individuals. And typically we present as nephritic syndrome, classical nephritic syndrome. The histological appearance is usually transient mesangial-capillary GN, and sometimes they present as mesangial proliferative GN. Anti-malaria drugs are still the cornerstone of treatment of the falciparum malaria, and most times the acute GN in falciparum malaria infection is usually reversible. Quartan malaria nephropathy affects usually children. When it was reported, it used to be very high with very poor selective proteinuria, and response to steroids was very poor. And in most patients progress to end-stage renal disease in about 5 to 8 years. More importantly, they graded the histological appearance into about 4, with grade 1 being a patient that has focal or segmental lesion with slight hypercellularity or increase in mesangial matrix. And grade 4 being generalized diffuse glomerular lesion with marked sclerosis, advanced sclerosing lesion. And you have varying degrees in between 2 and 3. The prognosis is usually very poor, and majority of them progress to end-stage renal disease. You could see diffuse glomerulosclerosis here with tubular atrophy in this patient, and you see some proliferative changes here, generalized. What about filarial nephropathy? What do we see? There are about 7 filarial worms, but 3 of them are notorious and could cause renal disease, Wuchereria bancrofti, Onchocerca volvulus, and loa. Adult Wuchereria worms are particularly known for invading the lymphatic system and causing elephantiasis. Filarial glomerulopathy could present in 3 major forms: acute nephritic illness, nephrotic syndrome, or renal failure, which is usually chronic. These are several authors that have worked on filarial nephropathy. What is the histopathology? All these histological types have been reported in filarial nephropathy. But more importantly, IgG, IgA, IgM deposits have been found in glomerular in almost all these cases. Ungu et al. In Cameroon look at complement deposits, or found complement deposits in about 60% of patients with filariasis, and found filarial antigen also in about 60% of them. This was equally found in the tubular membranes, and they found eosinophilic infiltration to be very common in there. What is the clinical cause? Antifilarial therapy was beneficial in acute cases. Nephrotic syndrome is usually unresponsive to therapy, and progression to end-stage renal disease is usually very common. That about schistosomiasis. This is the adult schistosoma worm. They usually will invade or reside in the lower urinary tract or the portal tract, the mesentery, or in the intestine. The adult schistosoma worms will secrete their eggs in water. Of course, these eggs in water will hatch into the meracidium larvae that are taken up by the different species of snails, the Bolinus, the Oncomelania, the Biomphalaria, for the different species of schistosoma. And in the host, in the intermediate host, which is the tail, they mature into Saccharia larva, which now penetrates man's skin while we wade through the streams. So this is a cycle as it repeats itself, and this is what has perpetuated their presence in the world till today. And what happens with the pathology? The release of the eggs leads to release of soluble egg antigen that forms circulating immune complex with antibodies that are produced to that antigen and leads to granulomatous reaction, and of course causes fibrosis in the kidneys. These are different presentations that we've seen in lower urinary tract diffuse bladder pathology, sandy patches, chronic cystitis, and sometimes squamous cell carcinoma of the bladder. They could cause obstructive uropathy, and they could cause nephrolithiasis. What about the Mansoni that is mainly intestinal? The same thing happens, but more importantly, it produces IgA and produces antigen-antibody complexes that get deposited in the glomerula in situ and stimulate inflammatory reaction. Which antigens in particular induce all these reactions that we talk about? They are ill-defined. So many hypotheses have been put forward. Maybe these are areas of research for those of us in this part of the world. The same thing applies to the antibodies. Those that have been recognized are antibodies to the tegument or gut wall of the worms, and the polysaccharide antigen of gut origin. And of course, what has been observed in them is usually polyclonal B-cell activation. So you find all forms of antibodies, anti-DNA antibodies, rheumatoid factor, anti-glomerular basement membrane antibodies, and so on and so forth. Circulating immune complexes consisting of schistosoma, antigen, and antibodies have been demonstrated in some of the cases. There have been particular hosts that have been known to be susceptible. Hosts with HLA-B5 are known to be particularly susceptible to infection with Mansoni, which usually will occur in association with intestinal polyposis. Those with A1 and B5 usually present with hepatic fibrosis, usually also with Mansoni, and they usually have advanced renal disease. And usually those with HLA-A28 usually present with classical glomerular disease. Schistosoma hematobium GN is reported particularly in association with salmonella infection and usually mesangial proliferative GN. Mansoni glomerulopathy occurs in association with hepatosplenic schistosomiasis most times, usually with a heavy worm load, almost 60% of them, Proteinuria is very poorly selective in them, and hypertension is very common in almost 50% of cases. These are other forms of other histological types that have been described in these cases. But I want to talk about amyloidosis in them because patients with schistosomal glomerulopathy are known to develop amyloidosis. Parasite antigens are sensed by the monocytes, and monocytes secrete interleukin-1 and 6. The interleukin-1 and 6 that are secreted stimulate the hepatocyte to secrete the amyloid A protein. And the monocytes take up this amyloid A protein and is read off from the circulation. However, when the stimulating factor continues perpetually, it overwhelms the ability of the monocyte to take up the amyloid A protein. And because of that, they deposit in the tissues, particularly in the kidney and some other tissues in the body. And there's chemoattraction, and of course, they initiate or perpetuate inflammation in these areas. This is the histological classification as was described by Basum, and some call this Basum classification. Professor Basum, by the way, was the founding president of AFRAN and one of our great mentors in AFRAN and my mentor when I was in Egypt. Mesangial proliferative could be minimal, focal, or diffuse, and with mesangial IgM, C3, and schistosomal gut antigen. The class 2 is diffuse exudative or endocapillary proliferation, usually occurs in association with salmonella infection. The class 3 is usually mesangial capillary types 1 and 3. And the class 4 is focal and segmental glomerulosclerosis. The class 5 is the amyloidosis that we've just described, and the class 6 is cryoglobulinemic glomerulonephritis, usually occurs in association with hepatitis C infection. This shows us a mesangial proliferative disease, and the immunofluorescence we're seeing shows schistosomal gut antigen in the particular patient. This is acute exudative GN, mesangial capillary GN, focal segmental glomerulosclerosis in this case, and we have the amyloid, which is class 5. What are the treatment options? Use of ozamniquin, praziquantel, nirintazole, metryptonate in types 1 and 2 diseases. Concomitant infection must, however, be treated. If they have salmonella, then we must treat it. If they have hepatitis C virus, then we have to treat it. Anti-schistosomal agents are not generally effective in other types. That is from types 3 to 5. Immunosuppressants have been found to be effective only in a third of cases, meaning that we need to really experiment more, conduct more studies to find out whether with the newer immunosuppressant we could have many more patients responding at that level. The other one, trypanosomal nephropathy, I won't waste our time on it, but it presents the same way, leishmaniasis. Toxoplasmosis in particular is important because what we could see in there is a reactivation of toxoplasmosis. Perez et al., even though it was a 1989 study, found 15% that 50% of patients had reactivation of toxoplasmosis. So it's really important to look at this. Hydatid cyst also causes problems. But what I'm interested in showing us is some of the newer drugs that have now been described in managing these patients. You could see Babesia, we could use atovaquone and azithromycin. Or secondary treatment, if the patient do not respond, we use clindamycin. For leishmania, sodium stibogluconate or meglumine antimonide, these are the old drugs. The newer ones, these sodium stibogluconate, but we now use fluconazole as the secondary treatment. Toxoplasmosis, pyrimethamine, traditional with sulfadiazine. And if they do not respond, we add clindamycin or clarithromycin or azithromycin, as the case may be. T-cruiser, trapezoidal cruiser, you use nifoctimos or you use benzimidazole. You can get details of these drugs from the slides I'm sure we'll be giving. For blastocystis, we use nitazoxanide. For cryptosporidium, the same nitazoxanide. For cyclospora, we use trimethoprim sulfamethoxazole. For E. histolytica, we use metronidazole, giardiasis, dinidazole, Isospora belli, the same trimethoprim sulfamethoxazole, Microsporidia albendazole, Schistosoma with the dog already, Echinococcus we use albendazole and surgery. Now let me quickly go to the fungal infections. The common fungal infections that we have in transplantation are listed: Candida, Aspergillus, Histoplasma, Blastomyces, Coccidioides. What I want us to note is that the longer the period of survival of the graft, the higher the chances of the patient developing a clinically relevant infection. And this has been demonstrated with virtually all organ transplants. You could see this from the Swiss transplant registry. More importantly, bacterial infections are the commonest, followed by viral infection. But we could see that the third one in this Swiss transplant registry were fungal infections in 7.5% of patients. I'm sure if we collect data from sub-Saharan Africa, parasitic infection will likely have a higher prevalence in this region. Just to let us know that Candida species occur commonly in early post-transplant period, usually within the peritransplant period and within the first 3 months. Aspergillus species occur within the very first 6 months of transplantation. However, all the others occur 2 to 5 years post-transplantation. What are the predisposing factors? There are environmental predisposing factors, there are patient-related factors, and the immunosuppression who equally contribute. What is the major factor in the environment that triggers this? Is the regional endemicity. This slide shows us how prevalent viruses are all over the globe. And we could see that virtually everywhere in the globe, you have one peculiar virus or the other. And we could see that you have more than 2 million fungal infections in a year. And you could have up to 1 billion globally infections, fungal infections. So we have fungi in everywhere. And the common ones we could see: Candida, Histoplasma, Cryptococcus, Sporotrichosis, and the rest of them. So they're very, very prevalent. And that's why with immunosuppression, you could have flaring of infection in them. What are the patient-related factors? Recipient and donor-derived factors. You have latent fungal infection in a recipient or in a donor, and the patient either receive or donate the organ. Of course, the recipient will then manifest the disease. Diabetes, particularly if it's poorly controlled, further reduce the immunity and predisposes patients to fungal infections. Prolonged dialysis, and the longer the patient stay on dialysis, the higher the chances that they may develop infections post-transplantation. When the patients develop rejection, you undergo different things to be able to correct the rejection, and that may predispose them to develop a fungal infection. And with transplant tourism, like we discussed earlier, patients could go to endemic areas for transplantation. Patients could travel to endemic area for transplantation, and patients from endemic area could travel to non-endemic areas for transplantation. So we could have spread of infection and manifestation of infection in these areas. And in particular, patients with viral or bacterial pneumonia, CMV infection and bacterial pneumonia in particular, maybe because they evolved from immunosuppression as well, have been found to be very prone to developing fungal infections. How about immunosuppression? The degree of immunosuppression contributes to development of infection. The immunosuppressive regime, as some of them have antifungal, antibacterial property or antiparasitic properties. So that will equally assist when we choose the ones that could fight against some of these organisms. Patients with leukopenia, particularly those ones that are on monoclonal antibodies, have the higher incidence of fungal infections or parasitic infections, and patients with rejection for reasons we've discussed earlier. Now for Candida albicans, Candida infections, there are 3 major species that are known: albicans, glabrata, and tropicalis. They are seen in about 76 to 95% of fungal infections. And usually the presentation is oral, esophageal, or genitourinary, and with disseminated infection occurring in fewer than 5% of cases. How do we confirm diagnosis? Culture of candida in the sterile sites and doing a polymerase chain reaction. How do we manage antifungal prophylaxis? Even though it's practiced in several transplant centers, it has not been found in meta-analysis to be useful. What about coccidiomycosis caused by coccidioiditis or Pudasasi? It's endemic. In endemic regions, about 3% of kidney transplant recipients could be infected. And the presentation is usually cutaneous, skeletal, pulmonary, and they could have meningitis as well, particularly in disseminated disease. Culture is confirmatory. Serologic assays can provide additional data, particularly for monitoring. How do we manage amphotericin, fluconazole therapy? After initial therapy, particularly if they now have meningitis. Lifelong azole suppression is recommended in these patients if they manifest infection. Aspergillosis is the third leading cause of fungal infection post-transplant and is seen in about 0.5 to 4% of them. How do they present usually? Infection of the lung, the sinuses, and other organ systems. How do we confirm diagnosis?
Please, Professor Fatiu?
I will stop in a few minutes, don't worry. Culture, direct microscopic examination, demonstration of histology in respiratory samples. And drugs use voriconazole, amphotericin B, and we must be conscious of the fact that amphotericin B is also nephrotoxic, so we really need to titrate it. What about histoplasmosis? It's seen in about 5 to 9% of invasive fungal infections. And how do they present? With pneumonia, and disseminated disease usually will present with additional cutaneous manifestations. How do we diagnose? Direct visualization of culture. And how do we treat? Amphotericin, itraconazole, voriconazole, or posaconazole. Now to the last one, blastomyces dermatitis causes blastomycosis, usually occurs 2 years post-transplant, presents usually with pneumonia in most cases, and disseminated disease usually will involve the cutaneous manifestations. How do we diagnose? Direct visualization of culture. And how do we manage? Amphotericin B, we transition to azole therapy after initial recovery. In conclusion, ladies and gentlemen, kidney disease secondary to parasitic infections are mostly immunologically mediated. Fungal infections, on the other hand, rarely affect kidneys alone. They usually present with sinus issues or pulmonary issues. Early disease are usually mild and sometimes self-limiting. Progressive disease may be secondary to yet unidentified factors, possibly immunosuppression, possibly some other superimposed infections. We've talked about hepatitis C, we've talked about salmonella infection. There's lack of adequate statistics, particularly on the prevalence of both. There's needs to be for specific diagnostic criteria, particularly for parasitic infections. And there's lack of adequate knowledge of specific nephrogenic antigens for parasitic nephropathies. The interactive effect of other conditions like viral infections, salmonella, malnutrition need to be looked at. And there's lack of control trials with more recent drugs. I can acknowledge with gratitude the support of these great men in history, Professor Rashad Bassoum, Professor Wale Akinshola. Both of them were presidents of AFRAN and introduced me into the world of parasites and kidney disease. I'm indeed very grateful to both of them. Thank you very much.
Thank you, Professor Fatiu, for this great presentation, and which opens the discussion. And I would like to let Professor Gloria to introduce first questions.
Okay, yeah, thank you, Abdul. Thank you, Fatiu. Please just keep the questions coming. The first question, just a minute. Abdul, please, can you go ahead? I have a problem.
I have one question about the availability of vaccination against VZV. I think it's for Professor Page.
Yeah, that's varicella. Varicella zoster.
Professor
That's
Page?
no, okay, for Professor Graham, yeah. Varicella zoster.
Professor Graham? Or can we give another question, waiting for Professor Graham answer?
Okay. So there is another question. Would you recommend doing BD glycan screening of recipients pre-transplant, especially in diabetes patients? Did you get that question?
We can give a question to Hussein. What do you think about urine LAM and its utility in EPTB diagnosis post-kidney transplant?
Okay, thank you very much, Prof. That's an excellent question. Because unfortunately, the urine LAM has not been tested in trials for kidney transplant patients. It's mainly been used for diagnosis of extrapulmonary TB in patients with advanced HIV. However, because of the fact that diagnosis of TB is very, very difficult, and you can extrapolate from that immunosuppressive state that HIV patients have, I have used the urine LAM for my patients, especially the one I mentioned who had an abscess, and the abscess was on the thumb, and he had been on antibiotics for almost 4 weeks with no response to treatment. And his urine LAM was positive, which now led us to do more invasive tests, which actually now pointed towards TB. And after starting him on anti-TB treatment, all of his symptoms resolved. We actually treated him for 9 months. And then subsequently, when we did all of his tests, everything was negative. However, 6 months down the line, when he was admitted now for hernia repair, he had some urinary symptoms and he got some epididymoarchitis, which was not responding to treatment. And when the urologist went in and removed the testis that was infected, he actually had caseating granulomas. So this was another very interesting case that we managed. And of course, now he's been on treatment for the TBs, and after discussing with my ID specialist, we opted to treat for a full year. So yes, it may be used, but of course the guidelines are not recommending the use of urine LAM in transplant recipients. Is mainly used for HIV patients with advanced disease. Thank you.
Thank you, San. And we have some question for Professor Graham. I don't know if we can have Professor Graham.
Sorry, Prof. Abdu, he has a problem with his microphone, so he's answering he's answering the questions in the chat, I think.
Okay, excellent. And we have another question for him. For Bika virus, we usually use sirolimus mTOR, which inhibit viral replication. What are your views, your opinion about that?
Sorry, I'm using my phone now. So is that
okay?
Can you
Professor
hear me?
Yes.
Okay, I'm using my phone. So sirolimus has a theoretical antiviral activity. It's not really included in sort of any of the major studies or guidelines. So one of the aspects of why it may help is that, as we know, it's not a great immunosuppressive agent. There's higher rates of rejection. So it might be more a fact that it's just lower overall immunosuppression rather than direct antiviral activity. So I guess it's not wrong. It's just it's not there's not much published on it. So it's an opportunity for you to maybe look at that.
Okay. As a question for, do we still recommend PGP prophylaxis? Currently, yes. And what does you recommend? Who can answer to this question?
Please.
I guess the question refers to pneumocystic carina, right?
Yeah.
Yes. It's the prophylaxis is not for somebody that has had infection before. Prophylaxis is recommended, but for a patient that has never had the infection, they do not recommend prophylaxis for PCP pneumonia. Thank you.
Okay, thank you. And a question for all of you: do you collaborate with infectious specialists? Nah?
Dr. Paget already answered that. He said they use in difficult patients as they have only 2 specialists. But what we do, we do not routinely involve infectious disease specialists in our team. However, when the patients develop difficult infections, we invite them. Thank you.
What about Graham? Your opinion?
Graham said it. He said that they use it only for difficult patients.
Okay.
Yes.
And you said?
I said we don't involve them routinely. However, when the patients develop infections and we are unable to treat it, then we invite infectious disease experts.
Okay, excellent.
I mean, it is the same with us as well. We don't routinely use the ID specialists unless if it's a very difficult to treat infection.
Excellent.
Yeah, there is a question about systemic prophylaxis of parasitic infections in endemic areas. What do you think about it, Fatu?
Systemic prophylaxis is not recommended generally. If a patient has had a particular infection, in that particular patient, you may recommend some prophylaxis for a specific period. But for fungal infections, for example, in the immediate post-transplant period, when we induce immunosuppression, many units will start oral antifungal in using nystatin. However, meta-analysis have shown that has not really been proven to be useful. So I'll say in some cases it is not recommended. Malaria, for example, that is endemic in our region, we do not give malaria prophylaxis to transplant patients, irrespective of the time, because it's not been found to be useful. Thank you.
Okay.
Excellent. For Hussein, do you have a comment on duration of TB treatment in post-transplantation?
Yeah, so as I mentioned that there are no studies done in transplant patients. It's basically the same guidelines that we use for the non-transplant patients. But of course, we do assess the patients clinically before opting to stop the treatment. Like as I mentioned in my own experience, what happened to one of my patients.
And in your practice, how many months?
No, so for example, if it's pulmonary tuberculosis, then we normally treat it for 6 months. As I said, it's the same guidelines that we use for the non-transplant patients for pulmonary TB as well as extrapulmonary TB. Of course, if it's something like pleural effusions, we just treat for 6 months. If it's CNS TB, then we treat for 1 year to 2 years, depending on the response to treatment after doing serial MRIs as well. So it basically depends on, I mean, it's the same guidelines that we use for the non-transplant patients who develop TB.
Okay, thank you, Sam. Any other comment, Professor Gloria?
So, oh my goodness. Hello?
Yeah.
I just have a question for Fatu. So, I mean, we don't really know the true prevalence of parasitic infections in post-transplantation. Why? Why don't we have that? Thank you.
I think the answer to the question will go to all of us, particularly those of us that work in parasite endemic zones. Why are we not reporting parasitic infections in our transplant patients? Abdul, Gloria, myself, we should all collaborate, look at parasitic infections that we develop, that evolve in our transplant patients, and report them. So we can combine everything and then it can make some sense. But we're reporting parasitic infections just 20, 30 patients. But if you are bringing all the patients together and you are reporting parasitic infection carefully planned in 1,000, 2,000 transplant patients, then that will make a lot of sense. And then we can say this is the prevalence in our environment. So the question goes back to all of us, both the speaker, the moderators, and the participants. We need to come together, design good studies, and talk about the prevalence. Thank you.
Thank you, Fatu. Gloria, I think we have new comment on the chat.
So go ahead. I have not seen it yet.
Not yet.
Mm-hmm.
No, I think it's it's all. And
okay. Somebody says in my center, we actually utilize our infectious disease specialists, both pre-transplant, as they really optimize our vaccinations, and as well during post-transplant. They add a lot of value, food for thought for African transplant teams. And this is standard practice in the West. So that's a comment.
Yes, absolutely agree.
well, thank you very much. From what Professor Paget said, they have 2 infectious disease experts in the hospital. Yeah. And you can imagine how overwhelmed they will be if you now bother them with transplant again, pre-transplant evaluation, during transplant surgery, and post-transplant management. They have their patients that they're managing ordinarily. So I would say it's something that we should consider, but the system may not be able to cope with it considering the number of infectious disease experts that we have. But we can get to that level. Thank you. But definitely, they will add value to the treatment.
Mm-hmm.
Thank you.
I would like to give exceptionally to Ifeoma. I think she wanna speak. Ifeoma, is it exact? No? Okay, Gloria, go on. Gloria?
Yes, I don't think we have any more questions.
Okay.
Mm-hmm.
We are at 6 p.m. With 2 hours of webinar. I think we can thank all the organizers and the participants. It was an excellent webinar with very great talks. I would like to thank Hussein Baga, Professor Graham Paget, and Fatu for their wonderful presentation. And we didn't see the time going on, and it was very, very fruitful. And thank you also for organizers for inviting me to moderate this very nice session. Gloria?
Yeah, I want to thank the transplantation team of AFRAN for the great job they have been doing. And I wish they continue same. It was really interesting. And thank you for inviting me.
Many thanks, Professor Abdu, Professor Gloria, all the speakers, Professor Hussein Baga, Professor Paget, Professor Fatiu for participating to our second webinar of AFRAN Transplant Committee. It was a great webinar. I ask my dear friend, Professor Ebon Bongboye, the AFRAN Transplant Committee co-chair, to conclude this webinar. Please, Dr. Bongboye.
Well, good evening, everyone, and I must commend everyone for staying on till the end. We've had 2 hours of very wonderful presentations. So on behalf of our chair, that's Professor Monji, I would like to, of course, thank both moderators, Abdu and Gloria, for adequately and properly moderating this session, and particularly to the 3 speakers who have done a wonderful job this evening. So thank you to Dr. Hussein Baga, thank you, Professor Graham Paget, and of course, also Professor Fatiu Arogunadi, and also to the 2 wonderful people who organized all of this, Gamal and Mariam. Thank you very much. So thank you to all of you who have stayed on with us throughout this webinar. And as you know, in another 2 months, we shall be having another one, and we look forward to having you join us again. So have a good evening, everybody, and please enjoy your weekend. Thank you.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
See you soon.
Bye-bye.
Thank you.
Bye-bye.